So here's a typical patient of mine that's a former model that no longer looks exactly like a model, and typical quadragenarian response in the 40s saying, why don't I get the comments I used to get? So this is my sort of assessment of this patient, and also we did a full face contouring, the same sort of video session with this girl. So we can just carry on with that.
This patient is in her mid-40s, a former model with excellent genetics. Here I'm drawing out the cheek form from the lateral canthus to the top of the tragus to the corner of the mouth, and then vertical straight down from the lateral canthus on both sides. Each side of the face are not twins, they're siblings. And is now showing that the right side of the face in 80% of the population has slightly more volume than the left side. Drawing this helps the patient and the injector see which side needs more attention. As she looks in the mirror, she's a very visual girl, she can see fairly quickly that it's the right side that needs a little more attention. And then I draw out also the cheek form shadow that's a youthful shadow that should be left alone. Here, this area should be not inflated or reflated at all. Each side of the face has a form shadow, one side more obvious than the other. You cannot have shadows without light. You can't have highlights without shadows. So leave that cheek form shadow that I've drawn there. And the submalar part of the cheek is where we're going to reflate. The nasolabial fold can be very obvious or less obvious, as in this patient. The lateral commissure down through the marionette zone, through the prejowl sulcus we draw out. And it's not a marionette lines, it's a marionette zone. And this is where she needs most of her attention. I've drawn out the head of the brow, the glabellar complex, and the radix as well. The temporal fossa needs a little bit of reflation, but just a bit, so there is some contour changes that's improved and not convex. So the patient can now see a little bit better what we're going to do. A lot of the H1 fillers, it's better to transfer some to BD2 syringes for better rheology. And here, this has a 31 gauge needle and an 8 millimeter length of needle, making a very tidy device to inject areas that are a little bit critical, making it very smooth even with good G1 prime fillers. Here I'm slightly reflating the temporal fossa deflated area and lifting the tail of the brow on both sides. And you'll see on the left side how I lift the brow a little bit so that we can get the strut work back into the brow and lift it up a bit. So raise the brow a bit, and then as you inject antegrade, it lifts the brow
and the swift spot.
Lifts the depressed fossa. Here we're reflating the submalar part of the cheek with a 1/2 inch syringe needle set up, and lift the area that's deflated subtly, and then inject antegrade, and that filling that you're injecting slowly creates the lift. So you're trying to form a biomimicry. We're just trying to mimic what this patient looked like a few years ago. And we're right on top periosteum, lift that area that's deflated, and as you inject antegrade, the filling creates the lift. So you're just trying to gently
this is Emerville, which
in a
you'll have
reflation
here
manner,
in a while.
not inflation.
Emerville Classic.
So it's like reflating an area of a beach ball that's slightly deflated. So we have her look like she did a few years ago. Essentially, it's the mimicking process. And on the prejowl sulcus zone, start right at the very bottom end and reestablish the strut work. You can use a regular 1/2 inch.
Notice I'm not fanning at all. We're just reflating by lifting. So we're in the subcutaneous
tissue. Lift that area that's deflated a little bit. As you inject and lift, the filling creates the lift. And also in the lateral commissure, make sure you get above the red of the lip so you get the angle of the mouth much more youthful looking. And once this is all reflated and contoured, then use cool ultrasound gel, blending, molding, and some areas massage. Massaging is the more aggressive of those three. Blending is mild, molding a little bit more assertively, to try to blend all the fillers into surrounding tissue so there's no detectable zones from injectable material to the treatment areas. And you can also detect areas that need attention. You can see immediately she sees the improvement, is very happy with it. This is her before photos with some deflation and contour issues, the map of where I injected. And then this is only 30 minutes later to see this nice, beautiful end result with no bruising. And I noticed that I've left that cheek shadow untreated and recreated the peak of her brow and the temporal fossa zone, giving her a much more youthful look.
Brian, go to video 4. Would be great.
You have any questions for Kent on that?
And you notice that girl had collapsed nasal valves on her nose, and we fixed that as well now. In fact, Arthur and I are going to write a paper on this. It's a very, very neat project, but it requires a number of steps, and it affects about 15% of the population in the United States. So if we look at the little technique of how to use your cannulas, if you think of a
This short video demonstrates 3 patients that have significant mid-face retrusion and deflation, but also fixed creases around the perioral area. And with the project of reflation and protrusion of the mid-face, it's important to also address the fixed lines around the cheeks and perioral area. Here, I'm using a 27 gauge cannula, 30 to 50 millimeters in length, with 25 gauge trocar. And the cannula is inserted very carefully to break up these fixed creases, almost like breaking up the septi in a grapefruit section. Here I'm using a technique with a twist, a twirl, spin technique that makes the entry much easier and breaking up these fibers. If you watch, I'm gently spinning the cannula. And here I'm on the left side where there's more significant sun damage and significant creases that are difficult to treat with any other technique. The cannula is inserted very gently, and the twist spin technique allows entrance much easier. And then once we've broken up the fibers, then we can start injecting retrograde and antegrade, and then molding with careful ultrasound gel. You can see I'm twisting and spinning very gently. Sometimes the video would exaggerate this. Here I'm injecting antegrade, retrograde. It also creates a little bit of volume. And then with collagen and elastin stimulation, over the next weeks, these patients really do very, very well. So gently mold and blend with ultrasound gel. And this next patient is a similar concept with multiple fixed creases and sleep lines. These creases are almost like a wrinkle, but they're a crinkle that have fixed creases. We break up those, and if you watch, I have this spin technique, this twist technique, at the same time injecting. Makes it much easier for the injector and much easier for the patient. So you break up these septi, sounds almost like bubble wrap, and then after they are broke up, then at the same time, then you go ahead and inject very gently small amounts of low G1 prime HA filler in an antegrade, retrograde fashion that creates the best result.
And we can talk about this a little later, but Arthur and I blend our products for this kind of procedure.
And reflation, not inflation, along with improvement of these lines and creases.
So let's go to let's see here. Go to 9. Actually, 8. Sorry, go to 8, because this is the one that's more important. Go to 8. Sorry, Brian. Go to 8. This is for the cannula technique along the jawline. And if you take nothing away from this meeting, this will change your life. Now, Nefertiti was this famous Egyptian queen, as you probably know. This is one of the most recognizable icons. And initially it stood for, Levy talked about this with using the platysma bands with Botox, but both Arthur and I believe that he was also injecting the tail of the parotid and some mandibular gland as well. But what you're trying to do with Nefertiti is obtain that nice youthful jaw angle, is what we're trying to create.
Nefertiti was a famous Egyptian queen, and hieroglyphics tell us this meant the beautiful one. She was not only beautiful in appearance, but the striking feature was the youthful jaw angle that was sought after. And when we try to reestablish the jaw angle, it's not just addressing the platysma bands, it's focusing on the tail of the parotid, postgel sulcus, submandibular glands, and masseters as well. We can shrink the masseters, parotids, and submandibular glands with neuromodulators. This patient shows the jowls that are a feature of aging patients and the labial mandibular fold along with the mandibular ligament. Our patient today is in her final process of restoration, and she has a significant uneven jaw angle and loss of the occlusive shadow that is so sought after. Our patient shows the tail of the parotid enlarged, the post-jowl sulcus, pre-jowl sulcus, and submandibular gland.
So the vertical line is the
in her
location
early
of
50s
the facial
with
artery.
significant facial deflation and descent and retrusion of the midface and loss of the youthful occlusive shadow. So occlusion shadow is a sign of youth. Here I'm injecting the jaw angle area with moderate G1 prime filler with a 27 gauge cannula, 50 millimeter in length, with a 25 trocar just in front of the predetermined facial artery, and inject subcutaneously and some pre-periosteal as well, and inject anterior grade and retrograde small amounts of product. You can guide the end of the cannula with the fingers of the smart hand. Inject small amounts, and this can be a very worthwhile event. You should be able to inject with the same trocar hold. Now I'm going anterior, and be aware that the osteocutaneous mandibular retaining ligament is a bit of a barrier that you must go through and inject around that through it and inject that whole zone. Mold, blend gently with cool-down gel so everything is in place and no areas of attention need to be re-injected. Now injecting the right side, just anterior to the facial artery, and a 25 gauge trocar.
I use more of a
27
gauge
gauge
trocar now and a
cannula,
25
50 millimeters
gauge
in length. And you'll
cannula.
see as we go along here that
It's
the
less wimpy.
mandibular retaining ligament is a bit of a barrier. You can go right through that, inject just past the pre-jowl sulcus, and small amounts of product, both anterior grade and retrograde. With this being accomplished, then
this one is called Bull lift, which you'll have shortly. It's just
subcutaneous and
just
a bit periosteal.
unfortunately, Volume and Bull lift are the wrong names. Bull lift doesn't lift, and Voluma lifts.
Now we're in the correct
So
plane.
they got the
All
names
filler
backwards.
sites have nice sweet
I
spots.
don't know how much you're
And
using.
as we inject
But I'm
gradually,
using
retrograde,
probably about
and we'll
0.7
come
cc
out
for
and
the
go through
whole
same
jaw
trocar
angle here
hole,
on each side.
and then go posterior, about the subcutaneous tissue above
And
the
I'm in sub-Q
facial
zone, and
artery.
towards the gonial angle,
Inject
I'm going
subcutaneous
pre-periosteal
and
here.
direct the
And it looks
tubular
aggressive,
canyon
but actually these
to
patients
the
hardly feel a
periosteal
thing.
space as well.
And it's
So
just
that there's
the
some
video
nice
often
contour
exaggerates
here.
it.
We not only reflate this area and contour it, but there will be some stimulation of collagen as well with time. This patient is quite observant, so she should notice a difference immediately after we've injected both sides. She'll see a nicer contour and a nicer occlusion shadow.
So you need to mark these out too in pencil some way
So
to
when
mark
you're done
exactly
with
the
this
jaw angle. If
project,
you don't, it's easy to
then
get above
the
a bull and
molding
you're
and
in the
blending
wrong
with
zone.
cool-down gel
All fillers
is
have
a must.
sweet spots.
Being very
So the
careful
sweet spot
to
here is
blend
right
and
along
mold,
the
very little
mandible,
massaging.
and blend
Looks
that all in.
aggressive here, but it's very gentle. And as the patient starts to
We use all different kinds of cannulas,
quite dramatic. Some
different
patients
brand
takes a while
names.
to see
There's
it.
ones from. So her comment is she sees it immediately.
You
So
see
that's
the results with this progression here with her retrusion of her face and loss of the volume of her cheeks and loss of that nice occlusion shadow of the jaw angle, and now we have that back.
okay. Let's do
Very
one
impressive
last
project.
one because
This
our
is
time's up. But I had a lot of requests for this collapsed nasal valve. So number 9. So that's the other thing. If you can learn while you're here, little steps to this one because it's fairly straightforward. So below number 9, it's about a 4-minute one, and then we'll break.
The external nasal valves are often ignored, overlooked, and confused, and are responsible for some of the major challenges with airway obstruction. The causes include genetic, aging process, previous rhinoplasties, and past injury. The anatomy is important to understand that this is a complex area that involves the valves as well as other structures. Common breathing apparatuses are found in both external strips and internal strips in athletes. Even in the equine industry, there is an interest in opening these valves. Here, this patient is at rest and breathing heavy. Transfer the G1 prime fillers to a BD2 syringe. Technique involves at least 4 steps: lifting the nasolabial angle, lift the base of the retruded nose, base of the nasal sills, and also the nasal lateral lobule of the ala. So in restoring the collapsed nasal valve, here this patient is a former model in her 40s. I've
So this
already
is the same patient that we had before.
restored the nasolabial angle up to its normal position of a
So
95
a real special
to 105
retractor.
degrees. I use a clear plastic retractor to hold the ala up and inject vertical. This is all done anterior
Right on top of the
grade
nasal sill,
with
which
a
is the
good
base
G1
of the
prime
nose.
filler transferred to BD2 syringe.
Intradermal.
Inject the nasal sills. You can see she's
Don't you hate it?
She's immediately can see the difference. The left side is more collapsed, and here we're going to now restore this as well, injecting the nasal sills as well as the lateral ala lobule, going right vertical at the base of the sill towards where the sill meets the lateral alar crease. Usually inject anywhere from 0.1 cc's to 0.2 cc's. Then after, we need to restore the actual alar lobule and stay above the lower lateral cartilage, this lateral crus. And this is actually intradermal injection. And as you reflate that nasal valve, then you can actually see the opening expand. So this structure is important to understand how this all connects together. This next patient is also in her 40s. And right now, the step 1 is to increase the angle of the nasolabial structure back up to 95 to 110 degrees. Hers was 75 degrees. This is done with a good G1 prime filler right on top of the nasal spine, holding the nasal tip up as you inject. And this is an excellent concept to start with the whole project. Hers is more difficult because she has stiffer structure. With the obtuse protractor, I was able to determine we were back up to 100 degrees. With the clear plastic retractor, hold the alar lobule up. She has much stiffer tissue than our last patient, so it's more difficult. Here I'm injecting right on the base of the nasal sill and injecting anterior grade with the G1 prime filler, 0.1 to a 0.2 cc volume. Inject very slowly and lift that whole external valve up, the lateral alar lobule, and includes tissue and cartilage, but still inject intradermal and stay away from the cartilage in most
It's important to lift
areas.
this up as you inject.
So it's a slow process, and then this is the second of the 4 steps. The first one was lift up the nasolabial angle up, where it improves the opening of the vestibule as well. And we already have some improvement. The patient has noticed that she's breathing easier. And here we inject this deflated areas above the valve. And then we'll proceed to the dome of the nose in this case as well and flow the product right across the cartilage. And then the last step will be to do
This
the
is
alar
one of Arthur's techniques as
lobule.
well, to flow that
This
along the
flows
dome,
right
along
along
the
top
cartilage.
of the cartilage and gives a better dome and a better structure. And this is actually tolerated very well by most patients, especially when we're using a 31 gauge 8 millimeter needle. And here I'm doing above
reflex tears.
this dome of the nose as well to help open those collapsed external nasal valves. Here I'm lifting above the alar lobule, staying above that lateral crust of the cartilage. So this is a very satisfying procedure. This nasal valve collapse affects approximately 45 million people in the United States. And this is the immediate results of this patient in her 40s, and showing the steps of the technique that you can stop and look at as you review this video. That clear retractor is a very handy device to use, and if we can open that external valve, it makes the breathing so much better, and a very satisfied patient. Is a fairly easy procedure rather than having surgery.
Now, the last was about a 2-minute, is just a patient I did last week that's a good double video, and you can do that, number 10. Then we're done. It's a side-by-side video of immediate before and after of a nasal valve correction. So she's breathing in here. You can see both sides. The left side is before the treatment and the right side is after. This patient was actually had a lot of tears. She was so happy about this. So you can see the collapsed valve here. It's kind of a neat procedure. Okay, thank you very much. Hey, Bob, do you want to take it?
Which way?
Well, are we having lunch or are we having lunch?
Well,
We have
I had
15,
lunch
we
last
have
week,
15 minutes?
so this is a first, and I am so proud to say that I've never said this to you before, but you're a half an hour ahead of time.
Right.
Oh,
So
no, hey, I'm leaving it up to Arthur, and he's always a half hour behind.
That's right.
So let's, Arthur.
Anything but Swift
Don't
is what
fight,
my name
boys.
is.
Don't fight.
So you're gonna have some comments, Arthur?
I have, maybe what I would do is just, after lunch, we're going to do some really interesting stuff with anatomy and injections, and I thought maybe I'll put up the slide portion of that now, because I can
that's
just
So go
good.
do that.
Let's do
Why
it
don't you do
now.
that?
Let's do that.
And
get you all
Any-
geared up for lunch.
How about if we take questions from the audience
Let's
based
do
on
some
anything
questions.
we saw so far?
I'm
the injection
surprised there's
technique?
not more questions. I thought we'd have all kinds of questions.
Well, we got some questions there. Okay, let me come on back
Get
there.
through here, guys.
And I'll tell you anything except
Always
where I
want to be
go
a game
fishing.
show host.
Got it?
I won't tell you where I go fishing. I have to kill you.
Yep.
We got one right here.
Thank you very much. Do you ever use fillers to support the internal nasal valve as well?
I have not done that.
I do.
Can you comment a little
Arthur,
more?
you want to
Where's
comment?
the question coming from? Is that from my plastic surgery colleague over there?
Yes.
It is, yeah. So you're talking about the location, the internal nasal valve, talking about between upper and lower lateral cartilages, the scroll area. Right. Yeah, I do that, but here's the trick. As a general rule, injecting in the nose should never be done intradermally. All injections of the nose should be done central. If you're doing for contouring, all injections of the nose should be done in the central location and down on bone or periosteum or down on cartilage. Because if you look at the layers of the nose, and it goes from skin, subcutaneous tissue, then there's a muscular layer, and beneath the muscular layer there's a fibrovascular area where a lot of the vessels are sitting, and then beneath that there's a gap between that and the periosteum is where you want to put the product. It's the safest place to put it, and midline is the safest place to put it. The nose and the glabella area, for most intents and purposes, are end arteries. That's why you're injecting anything around the nose or the central face, always monitor the glabella, because if the glabella starts to blanch, that's when you're intravascular, you're in trouble. It's the first indication that you're getting into trouble in the central face. The only time that I break that rule is in patients who have functional problems of breathing. If you inject under the dermis in that internal nasal valve area, which we're talking about is that you have a lower lateral cartilage, which we call the gull wing cartilages. They're shaped like the wings of a gull. And the upper lateral cartilage communicates with that through what we call a little scroll portion. The killer is that a lot of times when we do rhinoplasty surgery, we remove what we call the cephalic, or the upper portion of the lower lateral, so we disrupt that communication between the two, and as you were commenting on it, you get an internal valve problem where there's collapse. If you inject subdermally in that area, then you're pushing the valve down deeper and causing more of an obstruction. So we're looking to do something similar to a spreader graft. Spreader graft is support from below. What you're doing is you're putting in a bridge of cartilage underneath the nose to strut it or support it. So I got the idea, well, instead of doing that, why don't I do a suspension bridge from above? So my injection is intradermal because what I'm asking the product to do is, instead of allowing the skin to buckle in when you breathe in, I've now tightened the skin and made it like cardboard so that you cannot breathe it in. And the patient feels an immediate relief. So it's It's one of those breathe right strips, but intradermal. If you go beneath the dermis, you're going to worsen the problem. So I do that. That's a long answer for a very simple question. Sorry about that.
Other questions?
But we're going to get a chance to do that. I think there was a couple of people we saw that came up and said, can you do my nose? Can you do my nose? And we're going to show you some internal and external valve issues that we'll be able to hopefully try to correct.
Okay, let me come over here.
I'll tell you something else from my plastic surgical colleague over there is that my rhinoplasty reoperation rate has dropped right down to practically zero. And that's because of fillers. So much so that I've gotten so aggressive with the way that I treat patients post-op with these rhinoplasty patients is the fact that sometimes you have a little irregularity of the dorsum that you leave behind. I mean, I still do closed rhinoplasties, which mean I don't deglove the entire nose and take the skin off it. What I do is I work through the nostrils, and that vision is somewhat limited. We have lighted retractors and lighted headlights that we look inside, but a lot of it is by feel, and sometimes you leave a little irregularity. You take the plaster splint off the patient's nose, you take a look a week later, and you see there's a slight depression on one side. What's the first thing I do? I say, you're healing beautifully. They're lying on my bed. I said, but there's a little bit of swelling more on one side than the other. I'm going to add something in that's going to help the swelling go down. Well, thank you, Dr. Swift. And I take out one of those little BD2 and I put a little bit of filler in to bolster up the skin in that area. What I've done is I've put in a little scaffold or a strut. The patient's still healing. There's still bleeding, bruising, things that are going on. It fills in with collagen, it's like, having a little strut work. We used to have to take temporal fascia. We used to take cartilage from the ear. Now I just do that. And during the healing phase, it just doesn't settle back down again. It just stays there. So it kills your reoperation rate. It's fantastic. I do that almost immediately. And then I see patients who've had multiple operations. Remember, once you're injecting into an area that somebody's had surgery done on before, all bets are off. And I'll show you why in a second. You got to be ultra careful. You want to sleep at night, you got to be ultra careful. Go ahead. There's another question.
Thank you. Can you elaborate on the 50-50 mix on the HA that you were doing and where you use it?
Is that for me or for Kent? Kent, where do you blend?
I blend, that's a little tough question, but I blend with normal saline, more 50-50, and often I'll do 1 cc to a quarter cc and mix it really well. My nurses are very good at mixing it really well. I use it, for example, for forehead's a really tough area to use any straight up filler because the tendency with transferred light, reflected light, to get unevenness. So that solved our problem, right, Arthur, with blending? Right. So that's where I blend 1 to a half or 1 to a quarter there. And I also blend these fixed lines as well a lot with 1 to a quarter, 1 to a half. I blend lips as well. And the reason I blend lips, Arthur, do you blend lips?
Yes, all of them.
We blend lips. And I blend for tear troughs. I blend for infraorbital hollowing. We used to call that infrabrow hollowing. We used to call it A-frame. We've erased that so we can have compliance agree with us that it's infrabrow hollowing.
Right.
So orbital hollowing I blend. Because several reasons why. But it just flows better. It works really well. It stimulates some collagen. There's several reasons why we do that.
Yeah.
So
HAs are very hygroscopic. They love
very
water.
Hygroscopic.
They absolutely love water. Pure HA, if you were to take 1 gram of pure HA, it could bind 1 liter of water. That's crazy. It's the cross-linking that prevents a lot of the swelling. It's the free HA in a lot of these products that cause a lot of the swelling and the concentration of HA, which is why companies have been looking at moderating the content of HA and the way that they cross-link it. The problem is as you start to cross-link HA, you change its native form. It now has a different 3-dimensional structure. And now we're starting to see problems 6, 8, 9 months down the road because the 3D structure is being altered as the product is dissolving inside the body, and the body suddenly recognizing it as not being a native product. It's trying to recognize it as foreign. So it's a double-edged sword. But it makes sense to give it what it's looking for before you give it. And I've done this very often on demonstrations where I'll take one of the more robust HAs and I'll blend it 50-50 with an equal amount of saline or lidocaine. And then I'll take a big glob of it and I'll leave it on a gauze pad. And I'll do the patient's injection. Then I come back and we take a look at the HA on the gauze pad and we lift the HA up and there's no wet spot on the gauze pad. And gauze is one of the most absorbent things, which is why we use it in the operating room to absorb blood. Right? Why is that? Because once HA gets water, it doesn't let go. It will not give it up to anything or anybody. Certain HAs can expand to 5-6 times their weight. and certain ones are limited in the amount. And you understand that by understanding the personality of the HA, that some swell more than others. And I talk freely from the companies, and I said, there's certain products and certain companies that I will not use around the tear trough. Because if you get swelling in a cheek, big deal. It's a little bit of swelling, it's deep, it's underneath the muscle, you don't see much of it. But if you get it in a tear trough, which is the thinnest skin in the body, it's going to show. If you get it too much in the lip, you want some swelling in the lip because you want to get hydration, but if you get too much, then it's going to cause a problem. So understanding the different nuances of whichever products you're working with will help you. So in the old days, I used to treat tear troughs to about 60%, and it was killing me because I would get a beautiful result on the patient's face, but I would leave the tear trough wanting because I knew the product was going to absorb water. Well, what happened is you do a beautiful tear trough on a patient. If a patient leaves your office and you have nailed that tear trough beautifully, I can promise you that a high percentage to me is anything over 1%, but in a high percentage, probably closer to 10 or 15%, you'll have those patients come back after 5-6 months or even a year and say, look, I got this swelling, but everything was perfect for 5-6 months. What happens is that the product is looking for water. It's sitting there. It's waiting for water. The patient will cry because they break up with their boyfriend. They'll watch a movie and cry. She'll go out and have a couple extra drinks with her girlfriends and get a little bit of her swelling, sleep on her face, and the product's waiting for that water. It grabs it, doesn't let it go. Then you get the Tyndall because it gets too thick. So they get a bluish ball. But I understand it was perfect for 9 months, but now all of a sudden it's like that. So what we have a tendency to do is to undertreat that area and let the product do the rest of the work. But it's a guessing game. How much can it absorb? And then if you have to sort of top it up. So by blending the product beforehand, and I can talk about this freely because we're at a continuing medical education thing, you're giving the product what it's looking for, and I still don't trust it because all these products will still want a little bit more. So now when I treat tear troughs, I don't treat them to 60%. I treat them might be more to 80-90%. Patients looking better when they leave the office. But I had to leave them in the past with everything looking beautiful and a little bit of still an undertreated tear trough. And they'd say, well, why don't you put a little bit more in? You did such a good job. Because you're tempted to do that and don't. It's much easier to top up a tear trough than to melt it out. I use hyaluronidase, which is my second favorite injectable right now. Imagine that. It's going to be my number one injectable. Because I'm just seeing too much filler in people's faces, and most of my days are being spent melting things out. But when you melt in anywhere in the face, you're going to get extra fluid because the hyaluronidase changes the product from HA to water. So you're going to get extra fluid. The problem is the reason that you're swollen in the first place was because there was too much fluid overloading the lymphatics. And now you've added on to that, and patients get worse, especially in the tear trough. They're going to get festooned if you try to melt out some HA. And for a week, they're going to have these festoons until the lymphatics catch up, and they'll call you every day and drive you crazy. I don't need that. So what I do is I undertreat, and I'd rather add on than melt out, especially in the tear trough area.